So in the late 1980s, I was actually just completing my fellowship in interventional cardiology. It was actually an advanced coronary angioplasty fellowship with Jeff Hartzler, Barry Rutherford, and his partners at St. Luke's Hospital, the Mid-America Heart Institute in Kansas City. We had pushed the technology, I think, about as far as it could be taken, and there was really nothing immediately on the horizon that we thought was going to make much of a difference. Early in my practice, I was very interested, of course, not only in patient care, but also in clinical research and education, and I became aware of this course called TCT, Transcatheter Cardiovascular Therapeutics, which really was a boutique course for a small number of individuals who were interested in some of these newer emerging technologies. I was exposed to a whole new world of new approaches, of visionary thinkers who were looking about and thinking about coronary artery disease in ways that I had not imagined. And the ability to interact with people from around the world was a startling experience. I think the heart and soul of TCT has always been the live cases. It gives an immediate type of feedback, which I think provides a learning experience that can't be duplicated any other way. There's a rich tradition of live case education in interventional cardiology, and it really started with Andreas Grunzig. And then it transitioned from Grunzig to Kansas City with Jeff Hartzler and his colleagues. Then I believe they transitioned to TCT. And we're very proud of the way we've grown it over the years. I think TCT is truly unparalleled in the breadth of cases and technologies that are demonstrated in live cases, with the quality of the operators and the number of sites that are chosen from around the world. Very importantly, and we believe at TCT, that bringing the international experience to the United States is critically important. First-in-man studies are almost never done in the United States anymore. They're often done in Australia, New Zealand, South America, or certain areas in Europe. And to bring early device experiences in man back to the United States, to see them actually being done live, I think provides all the United States physicians and physicians around the world with new vistas, new horizons, new ways of thinking about coronary artery disease, and now, of course, endovascular intervention and structural heart disease as well. There was the introduction at TCT of the opportunity to be able to treat patients that I wasn't previously treating. It's a whole different type of experience and realization that yes, there are limitations to what you can achieve with just a balloon. And over the years, we were faced with incessant restenosis, with acute vessel closures. And then to go to TCT and to see the same kinds of issues, first of all, by some of the world's best operators, made me feel a lot better. But second, to see some of the new technologies being introduced that could be a potential solution for some of these problems. So this, I think, markedly increased, first as an attendee of TCT, my own sophistication and my own understanding of coronary artery disease, and I think that allowed me to take better care of patients even before those technologies were in my own hands. Then, of course, it just markedly increased my own drive to want to be involved in clinical research, in education, and at the cutting edge on courses like TCT, which ultimately, on a personal level, led to the great fortune that I had to join the group in Washington. For a couple years, I came to TCT as an attendee. I was working on a lot of projects and working on research in a group of 10 physicians, and we were doing research in interventional cardiology, and I was publishing fairly extensively back then, both abstracts and manuscripts. Marty Leon actually noticed, and one day I received an invitation to join TCT as faculty. At that time, I think when I joined, it was about 70 or 80 people. It's not now. We'll be up to probably 900 this year. So I came and I would present, one or two talks, and I would sit on one or two panels, and that was a very exciting experience. That lasted for approximately 4 years or so until I actually joined the group and became the co-director of TCT along with Marty. There was always an excitement level at TCT that didn't exist at any other course, and I really think it started with Marty Leon and his partners, but it was the format of the course. It was the combination of didactic teaching and live cases. It was the interchange, it was the panel discussions, it was the cutting edge topics. It was a whole, just combination of all those factors that didn't exist at any other course that quickly differentiated TCT from, again, any other educational venue in interventional cardiology and led to its explosive growth. Everyone who had gone to TCT was talking to their friends and colleagues, telling them that there was nothing else like this, that you had to come and you had to see it, and it is just eye-opening, and you will realize that there are solutions for coronary artery disease out there. So, anyone who was working in the field had to come to TCT, and it also became, I think, the ultimate networking opportunity, and that really helped to grow it. Physician scientists needed to be there, industry needed to be there. They wanted to learn about what the latest breakthroughs were going to be in the field. And I think for clinicians who wanted to take the best care of their patients, they felt that this became necessary to come to this conference to see what the leaders in the field were doing. At that time, compared to what it is now, it was relatively simple. It was only one room. It was only now what we call the main arena. While I was fascinated at all the new cutting-edge technologies that were being introduced, I also saw an opportunity to do what back then was considered probably not a wise idea, and was to try to make it appeal to everybody. Make it appeal to the average practitioner who is not going to be doing 10 lesion cases and complex chronic total occlusions, but had to take care of patients and wanted to learn how to deliver the best care to his patients. There really was no other course that was really satisfying that need as well.
All right, Fred, give him a wave. Look over at the camera here.
The first, I think, initiative was to make a large second room, which we called the coronary theater. The concept was always back then that the main arena would be for primarily investigational devices and new approaches that are off-label approaches that are not yet FDA approved, where in the coronary theater would be more for the average everyday cases, but being done by the superb leading operators in the world. And you had people that went to one venue or the other based on what their main interest was. And that led to, I think, an increase in attendance by probably 1,500 to 2,000 people within a couple of years. It then became very clear that the field of interventional cardiology was expanding. So we created the third venue, which was the, back then called the peripheral theater, now the endovascular theater. And then shortly thereafter, it became very clear that structural heart disease was going to be the next main arena. And then, of course, interventional valve therapies, which we believe right now is going to be the next big thing, and is certainly a very fertile area for investigation. So we created the fourth venue, which was the structural heart disease theater. TCT, I think, is a reflection of interventional cardiology, and I think the two are irreversibly linked. And I think TCT has played, if I can say this humbly, a central role in advancing some of the most important concepts that have been introduced in interventional cardiology, and TCT was very instrumental in introducing bare metal stent technology to the world, in bringing that technology forward and exposing it to first hundreds and then thousands of practitioners. And then, of course, that transitioned years later to learning and teaching about the limitations of stents, about what the causes were and the correlates of stent thrombosis and of restenosis, learning the evidence-based medicine as to who would benefit from stents compared to balloon angioplasty, who would be high risk for stents and whom surgery should be considered alternatively. So the emphasis shifted from what is possible to what is appropriate. And I think as the field of interventional cardiology has matured, that's become one of our key themes. Intervention is not for everybody, and we're always considering medical therapies versus interventional cardiology versus surgery.
Now in a non-obstructed state with, I won't say a resolved, but a ruptured plaque causing a non-transmural infarct, in the year 2000, should we treat this, or should we just treat this medically?
When intervention is appropriate, we want to choose the best device and the best pharmacology and the best approach and technique for the patient. And as bare metal stents transitioned into drug-eluting stent technology, TCT was at the very forefront of introducing that technology, first through some of the most pivotal and important randomized clinical trials for the four main drug-eluting stents, but many of the other drug-eluting stents also that have not worked out quite so well. We have introduced, and then they've gone by the wayside. So TCT has been critical in stent technology. Beyond that, though, TCT, I think, has played a very central role in, number one, advancing the concept of evidence-based medicine. We started out TCT, I think, 20 years ago, very much still in the phase of anecdotal medicine, or looking at observational studies and believing that we could tell from those studies what the right treatments were for our patients. And we learned through the initial randomized trials that our preconceived notions and what we knew from our experiences with our last 5 patients were often false. And this really ushered in the whole field of evidence-based medicine and the reliance and importance of randomized controlled trials, of very large, robust registries with very good, robust study procedures, and multiple other more sophisticated techniques to try to leave our experience of our last few patients and go to the science. And I do believe interventional cardiology, in part because of the emphasis the TCT has placed on evidence-based medicine, is leading every other field of medicine in the reliance and the performance of such large, important clinical trials. And that is one of the reasons we, again, humbly believe that outcomes are getting better for patients undergoing interventional cardiology. We believe that TCT really serves as an invaluable forum for the practitioner to be able to provide better care for his patients. It's really the one time throughout the year where the practitioner can come and hear state-of-the-art presentations, first overviews on areas such as adjunct pharmacology, the latest coronary stent trials, etc., to learn when those techniques should be applied, to learn how to apply them. Then the practitioner can watch live cases, the kinds of cases that he or she is doing every day, and he or she can learn and see what the leaders in the field think is an appropriate case to do, and discussions of the rationale as to why the person decided to do an intervention on that patient versus medical therapy or surgery, and why that person chose the technologies that he or she chose to treat that patient, that I think allows the audience member to be able to take home those lessons in a much, much more real and memorable way than just book learning or just seeing it on slides. I'm very proud of the breadth of TCT. The fact that we are not just now focusing on stents, but we focus on some of the most hardcore scientific topics, whether it be genetics and proteomics, whether it be cell therapy and angiogenesis, whether it be vulnerable plaque. The breadth of our field is actually extraordinary, and TCT is really approximately 60 meetings within a meeting. And if one looks, every aspect is covered, from interventional pharmacology to peripheral vascular intervention, again, structural heart disease, congenital heart disease, and all these emerging areas that are all under one tent, which has really made it the one place where anybody interested in any minimally invasive therapy needs to come. And it's an amazing interplay of audio-video technology, of multimedia presentations, of every aspect you could imagine that would make an exciting educational venue, which would hopefully be a memorable experience, provocative, exciting, stimulating, which I think translates into retention and knowledge at the end of the day. Basically, TCT is all about collaboration. It's all about partnerships. It's all about working together. No one person, no one institution, no one group knows everything. Every year we try to make it better. Every year we look, again, very critically at what we did that could have been improved from the year before, where we hit our marks, where we didn't, and it really doesn't stop. TCT will remain relevant in helping to promote and advance and educate the world on what the next level of advances will be, as well as how to apply the current approaches, drugs, devices, strategies, and techniques to the care of patients today. We love the process so much, and we do this because we do believe that TCT is contributing to the field, and it's helping in some modest way to advance the field of interventional cardiology, which is helping to advance patient care and improving the outcomes for our patients with cardiovascular disorders, and that's what really motivates us.